All right. I want to do a little recap of yesterday quick so that we can move forward with knowledge, so that we will be on the same page. And because as I go through Swan-Ganz pressures and we discuss peak, we have to remember certain things with our kidney, fluid, and electrolytes. And fluid and electrolytes seem to always kick students' butts, don't they? Yes. Do you feel what we did yesterday helped? Yes. Okay. Because it's very, the concept, it can be a little tough, all right? So now, if we have a blood vessel and we have cells that are right beside it, and if you have a diabetic patient, somebody who has lots of sugar in their blood, doesn't that make their blood hyperosmolar? Which means hyperosmolar fluids suck the life out of you. Hyperosmolar fluids suck the water out of cells to dilute the solute in here, correct? Correct. So that is why a diabetic ends up with shriveled up cells, black toes. They're diabetic neuropathy because the neuron's getting the water sucked out of it. So when we're talking about hypertonic fluids, you have lots of usually sugar or salt in here. And body wants homeostasis, so it's going to pull water out of the cell to dilute that blood, like our concentrated Kool-Aid, right? If we have hypotonic fluids, very little solute in here, like half normal saline. The osmolarity, and you've got to think, what does osmolarity mean? Concentration. So the osmolarity of a fluid is its concentration. The more concentrated it is, it's going to pull water out of cells to dilute that concentration. The less concentrated it is, hypotonic, the smaller the number will be too, right? Yes. On the IV bag, half normal has an osmolarity of 150. That's its concentration. Hypertonic fluids, anything that's hypertonic, is going to have an osmolarity greater than 308. 308 is what your cell is. That's the concentration. And normal saline is 308. So as long as we get that concept, you will know what fluid you would question in what, correct? Yes. Yes. So if you're given a test question, you know normal saline is isotonic, which means it doesn't move. Just like I'm butt clenching right now, I'm doing an exercise you can't see. It's isometric. A normal saline will stay in the blood vessel. We would not question normal saline if we were in hypovolemic shock. If we were losing blood volume, we'd want to replace it with saline. That's why every crash cart and co-cart has normal saline on it. Because usually when people are crashing, we got to fill vascular space. Their blood pressure is dropping, and we'll be doing all the shocks today. So we're going to talk about when this fluid's key in all the shocks because we want to replace the vascular volume, okay? Now, here, half normal that has less solute or less concentration is always used when we want to rehydrate cells. So hypo is low and goes into a cell. All the O's go together. And you would do that, you'd want that on that little old lady who fell on the garage floor. I've fallen and I can't get up. Bless you. Thank you. So we want that to help rehydrate her vascular. Now, a lot of times the doc will just order normal saline to fill the vascular and the cell will suck what it needs into the cell. But if we have a lot of damaged cells, we want to rehydrate them real quick. Where does potassium like to live? Inside the cell. So the serum potassium of 3.5 to 5 is the extra reserve, correct? Correct. So let's try to take that knowledge then we know, like when we said when we drew the labs and we pulled really hard and we caused the red blood cell to lyse, hemolysis, that gave us a false high potassium level, didn't it? Well, let's stretch our thinking a little bit. They give you a scenario that little old lady is on the garage floor for 3 days and with a broken hip. She's been laying in one position. What happens to cells if we lay on them and don't flip people every 2 hours? They break down. We call that rhabdomyolysis. So what's going to happen to the potassium level when they bring her to the ER? What's her potassium level going to be? High. How many cells died in those 3 days with that little old lady laying on the same spot with the broken hip and she couldn't move? Everything down through here was dying. Did not get circulation because she was laying on it. And when you have rapid cellular death like that, it's called rhabdomyolysis, and we end up with seriously high potassium levels. Now, one thing I want to go over with you guys is what you will have to do if you have somebody with those high potassium levels. So hypertonic fluids suck the life out of cells. Hypotonic fluids will go in and rehydrate cells. And isotonic fluids stay in the vasculature. Well, one thing I wanted to go over as we do our fluid and electrolytes, if you are in renal failure and you have every element is high, you have elevated BUN, elevated creatinine, you have got elevated potassium, sodium, chloride, phosphorus. What's your calcium? Low. What are the signs of hypocalcemia, hyperphosphatemia? Twitch, twitch, seize, Chobostic and Trousseau. So you're going to get twitching because you can't depolarize your muscles right. You're going to have seizures. You're going to go ahead and we tap your jaw. It'll spasm because it can't depolarize, right? Because it's not the proper balance. And it's going to go ahead and if we put a blood pressure cuff on your arm, Trousseau, it's going to go into tetany because we cut off all the blood flow. Now when we're looking at, if you had high phosphate and low calcium, would you give the calcium? No. What are you going to do first?
Binding.
Phosphate. Got to get a phosphate binder like Amphigel, Renagel, or aluminum hydroxide. Then you give the OSCAP. All right, when we do an EKG, I'm going to be talking about hyperkalemia. The Pwave. What does the Pwave represent? It is the atrial depolarization. Now remember, for depolarization to happen, we have calcium, chloride, sodium, mag, and phos all out here. And we're negatively charged on the inside and positive on the outside. He is resting or repolarized. When we get a stimulus that comes along, now they all play musical chairs, don't they? These guys all go intracellular, and does potassium like to live with other cells? He's like, oh no. Potassium goes extracellular, and all his friends now are in here. And he doesn't, well, they're not really his friends, they're crashing his party. All right? Why is this not raining right here? Well, I don't have time for it to dry. I already lost us. Believe me, I will be staying late to make sure you get your time if you want, okay? I'm sorry. Why is this not?
There you go.
I'm blowing the board.
Yesterday you just used water, right?
Yeah.
That's why I always gave you one dry, one wet, but anyway.
Yeah, I didn't have time to go. Yeah. Thank you. Obviously, you need to be my roadie. All right? All right. Now, all these guys have played musical chairs and potassium has exited the cell. And now we're negatively charged on the outside and positive on the inside, and that makes us depolarized. Oh, thank you, madame. Every muscle contraction, every nerve conduction has to deal with this. If your electrolytes are not in proper amounts, potassium, 3.5 to 5 milliequivalents per deciliter. Calcium's what? 8 to 10 cows in the pasture. Chloride, I always think of the little skinny bottle of Clorox as 98 cents to $1.05. Sodium, looks like 140 grains to me, 140,000. Mag, 2, 1.7 to 2.2. And your phos, 2.5 to 4.5. So if we keep our electrolytes in that balance, we can have cellular depolarization all day and have no twitching and no problems, no cramping, we'll be good. But the atria must depolarize. And when the atria depolarize, they force open the tricuspid and mitral valves, and that lets blood start to fill in the ventricles. When the ventricles fill up, it slams shut tricuspid and mitral. What heart sound is that? S1 is the closure of mitral and tricuspid. And you hear S1 loudest right here at the mitral valve, mid-clavicular line, 5th intercostal space. And when I would put my stethoscope here, and I will hear, "Look! Up! Look!" Second heart sound is the closure of aortic and pulmonic. Those are second intercostal space, right sternal border, and second intercostal space, left sternal border. So the closure of these two valves gives us S2. We only hear valves close. Like I should only hear this door close. Stenosis is a sound made when in these WD-40. Stenosis has an O for when the valve is opening. So we talked about some S3s and S4s yesterday because of right and left side heart failure. But you need to know what these sounds are and where they're heard loudest. Your heart is an upside down triangle. So the base of the heart is here and the apex is here. So on a test, if you were asked where would you hear S1 loudest, where would you put your stethoscope, it's going to be at that apex of the heart. Lump, lump, lump. S2's heard loudest at the base. Dum, dum, dum. Now as the atria contract, we fill the ventricles. So the P wave is not just atrial depolarization. It's also known as ventricular diastole, and that's what you measure when you take a blood pressure. When you take a blood pressure, don't you have a systolic over diastolic? Well, systolic, the QRS is your systolic pressure. So that is when the ventricles now have filled up and now they're ready to depolarize, squishing the blood to the lungs in the pulmonary artery and out to the body through the aorta. That is what you're measuring in a blood pressure. The force of contraction of your ventricles, and diastole is the force that's in there when the ventricles are dilating with blood. Now, the T wave is where we're going to start looking at some potassium issues. The T wave is just the repolarization of your ventricles. And what is repolarization? It's back here to our electrolytes. Then now he got done depolarizing, he got done having systole, and now they went oxygen free, everybody go home, potassium back in, calcium chloride, everybody go home. And now the T wave is when the ventricles are repolarizing, potassium's going back in, and all these guys go back home. But this is happening in milliseconds in your body, isn't it? My mouth is depolarizing very rapidly. Your hands are depolarizing right now, just doing that. Your head depolarizing, your neck, you're nodding. All these, you couldn't do any of these movements if your electrolytes weren't in perfect balance. That's why if you remember hypo and hyper potassium, hypo and hypercalcemia, didn't all of them have to do with cramping and twitching?
Yes.
Because doesn't every movement have to be in perfect balance with electrolytes?
Yes.
So that's why all of our electrical disturbances pretty much have the same signs and symptoms, except low calcium and high phosphate have the same. Twitch, twitch, seize, seize, chabastic and trousseau. That's unique to calcium and phosphate. So now the T-wave, one of the things that I want to go over is when we have, what happens when you have a potassium greater than 5? What happens to our T-wave? The T-wave gets tall and tented, doesn't it? So here for normal, this is 3.5 to 5. We have a normal T-wave. If potassium is greater than 5.5 to 6, we will have tall tented T-wave. Because the ventricle's having a hard time repolarizing because he has too much potassium in the way. He's got too much. The next thing that's going to happen, if your potassium's greater than 6, now you're going to have an increased PR interval and a tall tented T-wave. Which means it's going to take longer for the atria to depolarize the ventricles. Because now we got way too much potassium. There's not enough seats to sit as he becomes too much. So if they give you an EKG, it's not just a tall tented T-wave. You will have a slowing down of depolarization from the SA node to the AV node. It's going to take longer to depolarize. That's kind of like, I flew down 275 today and by Manatee Hospital because it wasn't a work day. Pew! But when you have to sit there on Monday, the traffic's slower. Well, the depolarization when you have elevated potassium from the SA node to the AV node is just like Manatee traffic. The one I'll be doing that later today, one-eyed kitty cat. When we have a potassium greater than 7, your atria stop depolarizing altogether. Now, I was Slackahoe Sally in the CCU, and when I used to float there, they felt the place I could do the least amount of harm was put her at the monitors. Let her watch the heartbeat. And she won't kill nobody there, hopefully. Well, they gave me one patient who was pretty stable. He just had a potassium in his IV, and he was getting discharged the next day. And I was watching the monitors. Well, about 2 o'clock in the morning, the pizza arrived. Now, if you're a night nurse, you know how this is like the highlight of your 12 hours, okay? Because you usually don't even get to eat. Well, I'd been watching the monitor. My dude had a normal sinus rhythm. He had 20K in his IV. I did not know his wife had brought him an Orange Julius slushie, potassium and oranges. I did not know she had brought him homemade banana bread. But yeah. So I missed this. It was good pizza. I missed the increased PR interval. It was very good pizza. I did notice it here. Where does P-waves go? Where does P-waves go? Thinking he'd gone into a junctional rhythm. Well, there was a really good nurse on, and she went in with me. And she said she saw the orange, she saw the banana bread, she saw the potassium. She said, turn off the IV, we'll call the doc, and we have a protocol for hyperkalemia. Let's draw his lab stat. He had a potassium greater than 7. And what did we do? Well, what did she do when I learned? We have all this potassium in here. Butt ton of potassium in your blood. So the first thing she did is IV push. Well, we do calcium gluconate. So first you do calcium gluconate because that will stabilize the heart membrane so like they don't die. Then she did IV push dextrose, sugar. Let's put dextrose in with the potassium. Then we did 10 units of regular insulin IV push. Insulin is the key that opens the cell door to let sugar in. So we put insulin in there. That's the key. That's the skeleton key that lets the sugar in. Well, where does potassium like to live? He's like, woohoo, the door's open. And it drives our potassium intracellular, decreasing your serum potassium, and you see your EKG go backwards. And then we give them K-exolate, and they poop out the rest. K-exolate, right? Now, had we not caught it then with that high potassium, he would have gone into the sine wave, which means he'd be signing off, which is where you have biphasic QRSs. The ventricles are not beating right, you're not perfusing, and you're like going to be wrapped in a body bag and have lots of paperwork. Sine wave. Sine wave.
Would that be your fault?
Would that be my
The
fault?
nurse's fault?
Well, we should have noticed the EKG changes. Whoever's watching the monitor would have been liable. Because aren't we, that's why most beds are going to monitor beds all across the U.S. That's why you need to know your tally. That's why you need to know what's going on in the heart. Okay, you need to understand rhythms, which we'll start to go over today. You need to get it in your brain because every bed will be monitored in the future because if we have electrolyte disturbances, you're supposed to be picking up on it. Because you talk about ABCs, this is the biggest circulation thing we got. It's the pump that pushes our blood through. So yeah, the nurse would be liable because she didn't pick or he didn't pick up on those EKG changes.
So after the widening and the tall tendon, it flips and then just does that upside
Does
down?
the sine wave. Yep. Because there's no atrial depolarization and the ventricles can't beat right. So it's called the sine wave. Are you warm? It is a little warm in here, I think. Yeah, I'm going to open this up because that is where the...
We're going to be
After class, look at the
So if the hyperkalemia works record, we automatically do these steps after we call
We
the
have
doctor?
protocols to cover
The
us. in.
facility
The
does.
facility has protocols.
According to
But
your
these are
facility.
standing orders.
Okay.
And she knew we had those standing orders. I didn't know we had those standing orders. I had never dealt with it. And a lot of these standing, you know how when you get hired and they say you need to review your policies and procedures and you never really do? I would suggest you do. Because things like this save somebody's life and you see the EKG go backwards. So that's how important, how much people know high potassium will cause a tall tension T wave, and hopefully you catch it there. Like catching the S3 for left-sided heart failure. But if you don't catch it, it progresses to death. Especially if they still have the potassium flowing in an IV. So anytime somebody has potassium in an IV, you gotta be watching that potassium level, you gotta be checking their electrolytes, you gotta be checking what they're eating. I did not realize that. And that's why you need to know all the foods that have potassium in it. You know oranges and bananas. What else? Nuts. Fruit. What else?
Anything from the ground and trees.
A lot of greens. If it grows up from the ground or dangles from a tree, chances are it has potassium. Yeah, because it dangles from a tree. And when you're looking at, what about mashed potatoes?
Yes.
And so here you have somebody who has 20 or 40 a K in an IV. They had some orange juice for the morning. Maybe they ate a banana, and then they go ahead and have mashed taters and gravy with dinner. And if they had renal problems. So you have to start, that's why I have a nutrition DVD. Because you've got to know magnesium, you've got to know potassium, you've got to know phosphorus foods. You have to know the real names of your vitamins. You have to, oh, and I will have, did I tell you guys, I have probably 10 more books tomorrow that the publisher sent me, if anybody wants one that goes with this. I didn't think I'd sell them all yesterday. All right, so are we you with me on this? What happens with hyperkalemia? And what you're not going to feed people? Nuts, potatoes. Does milk have potassium?
Yes,
Yes.
Why?
because the cow eats the grass.
That's right, and there's potassium in it. So ice cream has potassium. Milk. Cheese.
Is there anything that doesn't? It's probably be a smaller list.
Meat. The muscle tissue. It is a very hard to try and find low potassium foods. It's hard. Seafood doesn't really have, but salmon has magnesium. And in renal failure, you gotta know high salt, high potassium, high phosphate, because that's what they test, those foods. All right? Now we did right and left-sided heart failure yesterday. We're going to go over some shock and why we use normal saline, which is a isotonic solution. Let me get some water because I think that solution makes it too slippery. Yes. We are going to be going over EKGs, junctional rhythms, everything today. And the sheet, did everybody get the sheet I passed out? With the critical thinking? Connecting the dots?
Yeah.
No? Somebody said no?
Yeah.
Who did not get one? Because this is how we take, did everybody else get one?
Lo pencil. Lo pencil.
So this is how we take, I wanted you to just look at this, because this is where you have to learn to critically think. Where we have increased ICP. This one. There we go again.
You know, if you get like a terry cloth, almost like the ones you wash your car with, to wipe it off.
Good girl. Shall do. And I told Jan, I told my husband about that, we're gonna get the card reader.
You know, the
Yeah. All right. So you think you're getting a question with increased ICP, and we'll be getting to neuro. So you think, okay, pupils are blown, change in level of consciousness. So as a student, since you've only been taught in systems,